Um, my name is Sorab Zahidi. I'm a psychiatrist. This is the Honorable Judge Marino, and we're going to introduce ourselves. Okay, so for some housekeeping rules, uh, please ask questions because otherwise this won't be fun. But the thing is, please pinch it until the very end, and then we can have an interactive discussion as to what the questions are. Um, the distribution of the presentation is I will start with a number of clinical scenarios and stories to try to explain clinical commitment in the state of Connecticut through a clinical lens. And then the judge will take over and he will go through the legal steps that are required for somebody to get committed in the state of Connecticut. Okay. So without further ado, and at the end, if there are some references, but I didn't include them in the PowerPoints. If anybody wants my own write-up, feel free to email me and I'd be happy to share that. But hopefully it's understandable enough that you don't need the written material. Okay, moving on. Here we go. Now I'm stuck. Okay, the first scenario is this is just a hypothetical situation. This is a hypothetical situation, and I firmly believe it applies it could apply to many of you guys who work at the Root Center. Classic schizophrenia scenario, it's usually a 24-year-old or somebody in their late teens or early 20s, drops out of college, returns home, smoking a lot of weed, a little bit of dysfunction. Mom and dad are concerned because he's playing video games all day and not doing anything else. Eventually, he stops sleeping. He's up all night. He's acting bizarre. He's talking to himself, including having full-on discussions and arguments, and he's laughing inappropriately. He stopped showering. He's not changing his clothes. And before they bring him to the Root Center, let's say the local primary care provider is consulted somewhere, let's say in the state of Connecticut that is far away from a local hospital. So what ends up happening? At that point, in the state of Connecticut, any physician, any licensed physician can actually submit what is called a physician's emergency certificate. Now, this is going to come back up again.
Yeah.
The physician's emergency certificate can be filed by any physician. It could be an orthopedist, it could be a neurosurgeon, what have you. And once that physician's emergency certificate has been filed, the patient has to be taken to an emergency room. Once in that emergency room, and if you look at the statute, a psychiatrist has to evaluate the patient. Those steps that I put at the bottom of the slide are the steps that are required before somebody appears before Judge Marino. What do I mean by that? Young man with a history of schizophrenia, suspect of schizophrenia, sent to the ED. Let's say the patient gets admitted after the psychiatrist evaluates them. Then the psychiatrist, by law, has 15 days. The patient doesn't want to stay. Wherever the hospital is, they petition the local probate court. That judge will make a determination as to whether or not that patient should stay in the hospital. Let's say the patient stays in the hospital. Another 6 weeks go by and he's not getting better. Then the treatment team can make a referral to DMS. And if the patient continues to be compromised and in need of inpatient hospitalization, the patient gets accepted and comes to Connecticut Valley Hospital, which is in Middletown. That's where we find ourselves now. This is important because even me as a resident, when I was at UConn, I didn't fully understand how somebody ended up at CVH. Up to the point that somebody gets admitted made sense to me. But the CVH part wasn't clear. And usually it's a patient that doesn't respond and has to come under the care of DMS. Okay, so just leave it at that. Now moving on. Now this Johnny, I call him Johnny Sick because I think it's just a hypothetical scenario that you guys can maybe refer to when it comes to the Q&A at the end. Now, if I may, all right. Now, as a psychiatrist, I wanted to tell you a little bit about my own journey and how I came about wanting to learn about commitment. As you may or may not know, as psychiatrists, you go through undergrad, you go to medical school. I did my psychiatric residency training at UConn. Now, when I was a medical student, as much as I wanted to learn about different aspects of medicine, but I wanted to know why medicine did things the way they did. One of the outstanding questions for me was in my surgical residency. I mean, not residency, in one of my surgical rotations. What compelled a surgeon to take, let's say, a right lower quadrant hot appendix to the operating room? I always learned that it was a judgment call. Well, what does that mean? That means the surgeon decides to take that patient to the operating room or not. You can see something on CAT scan, you could have a white count, but ultimately the decision is the surgeon's. The question is, why does the surgeon even need to operate on the patient? That was the question that I had to pose myself. And at one point, somebody told me, well, there's a 5% chance of death if you leave that appendix alone. So for that 5% chance of death, the surgeon decides, you know what, we should go to the operating room, knowing that there may be even a chance that this is not a hot appendix. Fast forward to my psychiatric residency training. At that point, admitting a patient to the hospital, doing an adequate risk assessment, going through the process of hospitalization, that by itself, it's quite the experience. But some questions that I always ask myself, who decided that me as a psychiatrist should be the gatekeeper as to who comes in and who doesn't? And what determines the criteria as to why somebody should be hospitalized or not? I like to think I was a pretty good psychiatrist at assessing risk, but I didn't have answers to those questions until I actually did extra training as a fellow in forensic psychiatry at UCLA. What does it mean to be a fellow? That means I have extra training. Once I did my general psychiatry training, I did some additional training to try to find out exactly how is it that psychiatry and the law interact with each other. A forensic psychiatrist is double board certified, just like a child psychiatrist is, just like a geriatric psychiatrist is, just like a consultation liaison psychiatrist is. And the board certified forensic psychiatrist can serve as an expert witness. That gives you that additional level of training where you can come to court and give a clinical opinion, as opposed to just being a witness who provides the information as to what they saw at the time of the incident. This may not make sense now, but just bear with me. It will. It will. Now, like I said, patient comes in, we do an assessment. We all know this. You guys may see this in your clinic. You have a patient before you. The guise could be that, you know what, Johnny is smoking a lot of weed, but when you take a look at the patient, it's pretty obvious to you that the patient is psychotic. The patient is responding to internal stimuli. And in that sense, what is it that may compel you to send the patient to the ER? And that's the notion of grave disability. If the patient had clocked, let's say, the neighbor, or had become aggressive with his dad, or had said that I'm suicidal, that becomes a little bit easier. Why? Because we all know that dangerousness is the main criterion that gets you admitted. Now, let me move forward. All right. So digging just a little bit deeper into the issues of commitment, because what does it actually mean to commit someone? What does it actually mean to involuntarily hospitalize? And again, I did an adequate risk assessment when I was a general psychiatrist, but it wasn't until I became a forensic psychiatrist where I could answer some of these questions. If you really think about it, once you admit somebody to the hospital, what are you doing? You're holding them against their will. Just because they're admitted to an inpatient unit doesn't mean that you can treat them involuntarily. That's another process that you have to go through, right? So my question is, what am I doing for a patient that I'm admitting to the hospital? Is therapy enough? Is that adequate treatment? And this has been a question that, if you really want to dig into it, spans the last 250 years of history in the United States. And you have to have some familiarity with that to try to understand what is it that brings people to a hospital, and what is it that allows us, or me as a psychiatrist, to admit somebody to a hospital against their will and go through the various stages. So these are the questions that have come about. even in ancient Greece, people knew, and there's plenty of documentation that severe mental illness, that 1% that a lot of people have to deal with, existed. What did society do with those people? To the extent that they could, they put them away. Was there a place to put them away? Not always. And if there wasn't, the local jail did just fine. Right? Moving forward, the pre-colonial American colonies, they didn't have anything when it came to the mentally ill. All they wanted to do was to put them away and hopefully put them in a place where they're away from society and that they can be kept safe and everybody else could be kept safe. Fast forward a little bit, psychiatry comes about at the turn of the last century. The psychiatrist becomes the superintendent of many of the asylums. How is it that we started developing asylums? The notion was, you know what, maybe, just maybe if the patient is behaving in such a way, it's not necessarily that they're possessed by evil forces, maybe there's a disease in the mind. Religion still had a big impact on how we approach these issues. We figured that maybe if we became kind with the patient, there could be some spiritual salvation. We built asylums away from mainstream society so that labor, some religious teaching, and quiet and kindness could provide for a little bit of recovery. Up to this point, we just detained people. They hadn't committed any crimes, and you'll see why that's relevant in a moment. The doctor's judgment decided when somebody would come to the hospital, a lot of people got admitted without having any issues with mental illness. And I'll tell you an example now. I will give you an example in 1 second. What are the two principles? Now I'm dipping my toes into the realm of legal thinking. What are the two governmental principles that would allow for the government to detain somebody against their will, especially if they haven't committed a crime? The first one is parens patriae. Now, don't ask me, but I do know that this dates back to Magna Carta. It comes from English common law. That's where the state or the king has to act as parent for the subjects that cannot look after their own needs. What does that mean in present day psychiatry? That's the gravely disabled patient. The patient who's not necessarily dangerous, but we all need that he or she cannot look after his basic or her basic needs. That's the parens patriae principle. Police power is where the king or government has a role to play in making sure that society is safe from the person who is dangerous, or even the person who is dangerous is safe from himself. Until the last 100 years or so, whether it was dangerousness, whether it was grave disability, the psychiatrist, who was also the superintendent of the asylums that we erected, decided who came in and who got to be discharged. To give you an example, up to 1971, we would admit anybody and you wouldn't be discharged, anybody that we were deemed or the psychiatrist deemed to be a fit subject for confinement. Take a moment and think about that. Who is a fit subject for confinement? It's a very broad principle. You know, you could have a rebellious wife who didn't want to deal with the husband anymore. And the husband could actually petition the court and get the wife admitted. And the wife would have absolutely no recourse until the psychiatrist said that they could be discharged. It sounds a little bit cruel, but that's actually the history. I wasn't there, I didn't do it, but that's how the laws viewed how we should treat the mentally ill and how, what were the rules for them in being admitted to an asylum. Slowly, the courts started getting involved. One of the first cases was in Illinois, the Packard versus Packard case. This is the case of Mrs. Packard, who wanted to get out of the religious congregation that belonged to her husband. Lo and behold, the husband petitions, she gets hospitalized, and she cannot leave. So she petitions a court for habeas corpus to appear. And lo and behold, the court acknowledges that this woman has rights. She has rights. You can't just detain her in the hospital. You got to let her go if you're not treating her. That's when the nation noticed that, okay, all right, well, we can't just detain everybody, but not everybody paid attention. Moving forward. Now, this is, if I may, okay. Oh, I gotta go back.
Go back.
I know, I messed up, sorry. Okay, so this is my last slide. And I sort of have a little bit of fun passing on some of these different cases. And these are the cases that I learned about in my forensic fellowship. These are the cases that answered the questions, where do some of these terms come from? Where do some of these laws come from? Who decided that we have to look for the least restrictive setting? Who decided that, you know what, it's not just need for treatment that allows us to admit somebody to the hospital. There has to be dangerousness, there has to be debilitation, there has to be grave disability. Then I also learned about the different standards of proof that are needed for somebody like the judge to admit somebody to a hospital. Because if you really think about it, for a woman to be admitted to the hospital just because her husband said so is a huge deprivation of civil liberties. Huge, huge. So, you know, what are the remedies that are available to these folks? Now, let's just go down some of these cases. Hopefully, I can give you the fun aspects of each, and you can remember where some of these terms of art may have surfaced. The first one is 1966. This is the story of Catherine Lake versus Cameron. This is in Washington, D.C. Long story short, there was no doubt. Nobody doubted the fact that Miss Lake was suffering from schizophrenia. She gets diagnosed with an acute brain syndrome, gets admitted to the famous St. Elizabeth's Hospital in DC, and guess what? She's stuck there. She is stuck there. She petitions the court and eventually appears before a DC Court of Appeals, on which we had the great David Bazelon, who was one of the appeals court judges at the time. Judge Bazelon was a big proponent and champion for the mentally ill. And Judge Bazelon came up with this term of least restrictive alternative. Well, what does that mean? That meant that for when it comes to a patient, once you admit the person to the hospital, if you can find a least restrictive alternative, you have to discharge them. If it's safe to discharge them, you have to discharge them. Well, what does that look like? Well, the court has to play case manager. Is there a halfway house that's available that could help out the patient? Is there a skilled nursing facility that could help out the patient? Unsure, but you have to look into these matters. Also, Judge Bazelon decided that for a psychiatrist to come and testify that this person needs hospitalization, you need a very thorough and independent assessment of the chart and the patient. This will come up later. Hopefully I won't interrupt the judge too much, but it will come up later as we go through the Connecticut statutes. 1969, the Lanterman-Petrus Short Act. This, along a small, the name is escaping me, but around the 1960s with the civil rights movement and a lot going on in the United States, the atrocities committed in the asylums came into the public's consciousness, and the courts became very much involved, took away the power from the psychiatrists and reduced the criteria for who could be admitted to a hospital down to two: dangerous to self, to others, which is this is not news to you guys, or the patient is gravely disabled. The Lanterman-Petrus Short Act was actually a statute passed by the state of California. You know what they say, when California sneezes, the rest of the nation catches the flu. And that kind of thinking started spreading. The court has to be involved. It can't just be the psychiatrist's clinical judgment. The court has to give the okay to hold somebody in the hospital against their will. 1972, this is a Wisconsin federal case, Lessard versus Schmidt. Alberta Lessard, again, no doubt that she has schizophrenia, no doubt that she was dysfunctional. The question was, what needed to happen before Alberta Lessard could be admitted to a hospital against her will and kept there? This case actually caught the nation's attention. Why? Because the opinion rendered said, when you're holding somebody in a hospital against their will, they may not have committed a crime, but you holding them is just as bad as if they had committed a crime. So what does that mean? You have to use the standard of proof that is that of beyond a reasonable doubt, which is what is used in criminal cases before somebody gets incarcerated. Lessard versus Schmidt was huge because the beyond a reasonable doubt standard, and the judge can speak to this, is quite high. And we can't put numbers on it, but that's exactly what I'm about to do. You got to be 90 to 95% sure that somebody is responsible for something before you can put them in the hospital. My question for you is, which psychiatrist can come and testify with 90 to 95% certainty that somebody is either dangerous or gravely disabled because of mental illness? Put that on the shelf. 1975. I like this case because I just like to say Chattahoochee. Donaldson, O'Connor versus Donaldson. This is a case that pertains to a state hospital in the state of Florida called the Chattahoochee State Hospital. I just like saying that. Unfortunate case because Kenneth Donaldson, again, no doubt that he was sick, but it was his father who brought him to the hospital to treat him. I think he got into it with the head psychiatrist, who was Dr. O'Connor. Dr. O'Connor elected to keep him there for 15 years. So I would say at that time, a quarter of his life has gone by, and they didn't provide him any quote unquote treatment. There are people in the society who were willing to take Mr. Donaldson, but Dr. O'Connor still refused to let him go. This case made its way to the Supreme Court of the United States. And I thought it was actually quite funny because one of the opinions rendered was, if you have somebody with mental illness who is non-dangerous, you cannot keep them in the hospital without treatment if you're not doing more. They never define what more means. Well, what do you mean? You cannot keep them in the hospital if they're not dangerous without more. Now, there are legal scholars who think that that means that you cannot admit anybody who's not dangerous. Others who say that if the person is not dangerous, you have to intervene and do something for them to restore their mental capacity to look after their basic needs. 1977, this is a fantastic case from the state of Connecticut. Fasulo versus Arafe. This is the case that made its way to the Connecticut Supreme Court. In short, it related to Connecticut Valley Hospital, the patient petition. Why? Because once you check into CVH, there was no recourse. There was nothing you could do in terms of you getting out. So the Supreme Court said, no, it's a violation of due process rights. The court has to go back and check on the patient and make sure that they meet commitment criteria and review this at least on an annual basis. And this is the grand poobah at the very end. This is 1979. This case is Addington versus Texas. This is the Supreme Court case that established the clear and convincing standard of evidence. What does that mean? Let me stop right there. We as mental health professionals, we as clinicians, whenever we get sued, it's a civil matter. The plaintiff has to show in a court of law by what standard? The preponderance of the evidence. What does preponderance of the evidence mean? That means it's more likely than not, 51% to 49%, that let's say Dr. Zahidi committed malpractice, therefore he ought to be sued. What is the standard of care when it comes to the court finding somebody, let's say, guilty of a crime to incarcerate them? That standard is the beyond a reasonable doubt standard. What does that mean? That means American society would rather let 10 guilty people go free than to incarcerate somebody who is innocent. Having said that, the beyond a reasonable doubt standard was what Addington argued in this case, that you're holding me in the hospital against my will, you have to find me guilty just like I had committed a crime. Long story short, the Supreme Court said in the Addington case that no psychiatrist can actually take the stand and argue beyond a reasonable doubt that somebody is mentally ill and gravely disabled, or mentally ill and dangerous. Beyond that, the preponderance of the evidence, which some states were using to hold somebody against their will, was not adequate protection for somebody to be held in the hospital against their will. Okay, so the Supreme Court decided in Addington versus Texas that we're going to do an intermediate standard, which is the clear and convincing standard. Okay, Addington still applies today. These terms, based on these cases, you're going to hear next when Judge Marino goes through his slides with you. Now, I just want to before I go hand it off to the judge.
Back to that then when you have a chance. No,
which one? Which one?
That one. But why don't you finish?
Okay. Just to recap, before I hand it up to Judge Marino, when Johnny Sick is, let's say Johnny Sick is admitted to UConn. Let's say Judge Daly up in Farmington holds him in the hospital. Let's say the team applies to DMS, and let's say the patient comes to Connecticut Valley Hospital. Once the patient is in Connecticut Valley Hospital, by law, the court requires 2 psychiatrists to come and see the patient. Once I finished my training in general psychiatry, I came to Connecticut, and for the past 13 years, I've been doing a lot of commitment evaluations and opining for the court. And I'm up to 1,000 cases at this point. And I've been doing this for a minute, and I have a lot of experience doing this. So when I interject with what Judge Marino says, that's just based on my own experience and where psychiatry, clinical medicine, and the law may conflict with each other. Okay, let me just leave it at that. I'm just going to hand it to the judge.
Okay.
Here we
go. Right there.
Go right.
Hello, everyone. I'm Judge Marino from the Middletown District Probate Court. I didn't realize that we were going to go back to Greece there, Dr. Zahidi, but thank you for that history lesson.
Ancient Greece.
Ancient Greece. That's even more, yeah. I thought they killed everybody at that point.
Right.
But I want to talk about these cases just very, very briefly, just to let you know that the state of Connecticut has really adopted, most of these holdings that these courts did, whether they were the state Supreme Courts or the United States Supreme Court. To the 1966 case, they say the least restrictive alternative. Our language, which we'll see shortly, is that the court has to find that there's no less restrictive placement available. Essentially the same thing. Dangerousness we have defined, we meaning the state of Connecticut, as a substantial risk, not imminent, but substantial. We did not adopt it beyond the reasonable doubt. That's much too high of a standard, as Dr. Zahidi said.
I believe California still does.
It is in the 95% range. O'Connor, we have the safety net of grave disability. And that's probably the majority of most of my commitments over the years deal with grave disability. Fusulo, the 1977 case, that's the only state Connecticut case that's on this list. Very, very important because Mrs., I think her first name was Ann Fusulo, was at CVH for 26 years. 26 years with no reviews whatsoever. She was just locked up. I'm not sure. I would assume she was receiving the benefit of some treatment, but no reviews by any court. There was no statutory authority for her to really request a review. So the court stepped in and it got to the United States Supreme Court. And Dr. Arafat at the time was the superintendent of CVH. And the state Connecticut Supreme Court said that you have to have at least an annual review. And we're going to get into what that means. And then the 1979 case, the state of Connecticut has adopted the clear and convincing evidence standard. So you cannot keep somebody within a hospital unless the proof rises to the level of clear and convincing. So
can I move on?
You can move on.
You got to introduce yourself.
Okay, well, I guess I sort of did. You can read that. It's not particularly, we are elected. We are the only judges in the state of Connecticut that are elected. We run every 4 years. So I have been the Middletown District Probate Judge since January 1987. I won the election November of 1986. You get sworn in early January, and so it's been about 37 years plus that I've been the Middletown District Probate Judge. Now, being probate judge means absolutely nothing. There's 54 of us, and we may not know anything about mental health law. But the bottom line is that our court's jurisdiction is facility based. So if you don't have any of these facilities, any of these behavioral health facilities within your district, you may never see any of these matters that come before you. But as you may or may not know, Middletown has Middlesex Hospital. You probably know that. We have Connecticut Valley Hospital, which is really the only long-term psychiatric facility left in the state of Connecticut. We have Whiting Forensic Hospital, which is the only forensic hospital in the state of Connecticut. And we are also blessed with Solna Children's Psychiatric Hospital. So whatever comes out of those 4 facilities, I think it's 4, they all have to come before me. So,
Sorry about that.
all right, and that would involve civil commitments, involuntary medication, shock therapy, contravators, probable cause hearings, and also substance abuse commitments. CVH has a substance abuse addiction unit up on the CVH campus, which is a whole separate set of statutes. And so I've probably in my 37 plus, well, not probably, I have done tens of thousands of these cases, literally. I'm not exaggerating over the years. I probably average 15 to 20 mental health matters a week, times 52 weeks a year, times 37 years. You could do the math. So next slide, please, doctor. All right. Now, it's important to note that our mental health statutes in the state of Connecticut, they start at the age of 16. So not at 18, which is the age of majority, but at 16 years of age or older, that's when all of these statutes that we'll be speaking of come into play. If you're under 16, there's a whole separate set of statutes, somewhat similar, but not exact. They're, kind of loosen the standards a little bit, keeping in mind the fact that we're dealing with really children at that point. And as I said, as I think I stated, probate court have exclusive jurisdiction over civil commitments and over all these matters, for that matter, involuntary med, ECT. Now, what does that mean? That means that your local probate court, wherever the facility is the only game in town. So we don't have what's called concurrent jurisdiction with the Superior Court. So you have to go into your local probate court. The only times that Superior Court gets involved is if there's an appeal from any probate court decisions involving this, then there's a 30-day appeal period from the date of the court's decree. Hearings are closed to the public, which I violate every single time that I have a hearing. I'm a firm believer that a large part of what we do, there's an educational component to what we do. So I'm going to invite you all, which I'll talk about at the end. You can certainly attend, and I'll give you my email at the end. You can attend any of my mental health hearings, which are held over at CVH and Whiting every single Friday. And I mean every single Friday for the past 37 years, except for holidays, obviously. I always invite PAs, APRNs, law school students, other doctors, whatever, because I know there's a large educational component to what we do. Next slide. All right, definitions are really key. You don't necessarily have to know all the nuances of the statute, but you have to know the basic definitions. So we start with a person with psychiatric disability, and you could read the definition. I'm not going to read it for you. But what is important, because I know the Root Center is very involved with this aspect, that it specifically excludes a person who's an alcohol or a drug-dependent person. There's a whole separate set of statutes dealing with that. I've been doing more and more substance abuse commitments over at the Addiction Services Unit on the CVH campus. It's over at Merritt Hall. I've probably been averaging 1 a month now. It used to be a lot less than that, so I'm not sure what's going on there. I think it's a philosophical difference, perhaps, voluntary treatment versus involuntary. But that's a whole separate set of statutes, which I don't believe we're going to be discussing today.
Judge, can I just interject for 1 second?
Yes, you're not interjecting.
Well,
Please.
if I may, just I didn't know what a statute was until I did my forensic
You thought it
fellowship.
was a statute.
Yeah, I did think it was a statute. And no, but a statute is something that is passed into law by the legislature. You know how I presented those various landmark cases. If a state really likes the constitutional decisions that are made,
Right, they
then-
codify.
right, they codify, they turn that into law. So when the judge said these are statutes, that means it's Connecticut law. It's in the
Right.
Connecticut legal rules of how we do things in the state of
Right,
Connecticut.
which we have to follow, you know, as judges and also as doctors too. You have
Right.
to be aware of it. You have to know what the terms are and what the judge is going to be looking at in order to make his or her decision.
Now, one more thing before I move on, I'm sorry to interject one more time. Again, this statute, for those of us, well, how do we diagnose mental illness? For us, like the DSM is our Bible, but as you can see, the law has its own definition. What is a psychiatric disability? Somebody with a mental or emotional condition that has an adverse effect on their ability to function. That was another thing that I had to wrap my head around. Why is it that the law has a different language than when it comes to my Bible, which is the DSM?
Right, but the laws are our Bible,
I got you.
right? And they don't always mesh.
That's true.
I guess it depends upon the version, the King James version versus the other version.
Or
so.
the yes.
Whatever the other version is, I don't even know.
Right.
All right, so dangerous assault for others. The key term here is that there's a substantial risk. I don't like when people say that it has to be imminent. There's nowhere with the statute is the word imminent. So it has to be a substantial risk of physical harm either upon themselves, which makes them dangerous to themselves, obviously, or upon another person.
Judge, I got to interject. I'm sorry.
Again?
I have to interject. I'm sorry.
This
I'm
isn't
sorry.
working out.
I'm sorry. I
only
apologize.
busting
I
you.
have
Go
to
ahead. You don't
interject.
want to apologize.
Okay,
I'm just
so
giving you a hard
for
time.
the clinicians out there, two things, and this is something that I like to pass on when it comes to psychiatric residents at UConn. Number one, there is no chronology to the definition of dangerousness in the state of Connecticut. Do you pose a substantial risk of harm to yourself or to others?
Physical harm.
Well, it doesn't.
Yes, it does.
Well,
The statute says
okay,
physical
so
harm.
here's my question. If somebody killed somebody 4 decades ago, do they pose a substantial risk of harm to others? I think that's, I would argue, yeah, you still pose a substantial risk. But if you guys remember that case from Wisconsin, Lessard versus Schmidt, Lessard versus Schmidt reduced the dangerousness criteria to an overt act that has happened in the last 30 days. I can tell you, in the state of Pennsylvania, they still follow that. If you try to hang it up or commit suicide 31 days ago, you cannot be committed. You cannot be committed. So the word imminent belonged to Lessard versus Schmidt. Some states still use it. Okay, I'll be quiet now.
I think that's ridiculous, but that's just me.
No,
So,
I mean, how do you?
I don't mean you, I mean the term, because
imminent.
it doesn't go that way. You know, we can't. To get to your point, someone committed the murder 40 years ago. I need to know about that, you know, when I'm having a hearing. It goes towards weight. It goes towards
I
weight.
agree.
How do I weigh the evidence?
I agree with
So
that.
the fact that it happened 31 days ago, you're not going to tell me because you're in the state of Pennsylvania? I think that's
Well,
I think that's silly.
The law is the law.
I
I
know.
agree.
I know, but it's a shitty law. That's all I can tell you.
We're going to be on YouTube.
So I don't care. All right, so most of my committees fall under the more, you know, kind of generic, kind of, you know, squishy term of gravely disabled. And you could read what it means, but it means that they're in danger of serious harm as a result of their inability to provide for their basic human needs, food, clothing, shelter, safety, things of that nature. So that is a majority. That's, you know, definitely more than 50% of my you know, my civil commitments. Next slide, please.
If I got to interject one more time, the grave disability goes back to that parents patriot principle, where the government looks after the subjects that cannot look after their needs. Many have tried to do away with that, but regardless of the state that you practice in, if you actually look into the language of the statute, there's always a line or two that pertains to the people who cannot look after their own basic needs. All right, involuntary commitment.
All right, so now we're going to get into the weeds a little bit concerning civil commitment. Petitioner can be any person, but it's 99.99%. It's going to be the hospital where the respondent, they're called the respondent, but the patient's located. Because if you're just a regular person coming into your local probate court, you want to commit somebody, how they're going to be served, how are they going to be found, who's going to pay for the for the two independent psychiatrists, which we'll get into shortly. How you going to have the hearing? You have to drag the person against their will versus they're already in the hospital. So it isn't a statute that it can be any person, but I've never actually seen it exercised. And then once again, petitions filed where the response is hospitalized, which we talked about a little bit, because it's got to come to that probate court.
So you can't do probate for Farmington, Connecticut?
I cannot, no.
Okay.
Next. Okay, importance of due process. Dr. Zahidi already kind of touched upon this. Because when you are civilly committed, you are committed for the duration of your psychiatric disability. We can talk about reviews, periodic reviews by statute coming up shortly, but that's what it says. So, think about what we're doing. We are confining somebody against their will. I often say that being civilly committed is really worse. It's worse than a sentence of being in prison, because when you go to prison, absent if you're sentenced for life for a very heinous crime, you know how long you have to serve. You may be sentenced for 5 years, and you may get some time off for good behavior, and then next thing you know, you're out. But when you're civilly committed, it could be for the duration of your psychiatric disability, and that could be, quite frankly, I've seen folks now, because I've been doing this for over 37 years, that have been at Connecticut Valley Hospital for longer than I've been a probate judge, and they're probably going to end up dying there. So unfortunately.
If I may just interject.
Yeah.
If we could go back to Johnny Sick when I initially presented him, just follow my lead. Let's say
Okay, all
Johnny,
right, we'll go with
or
it.
let's say Johnny gets it hospitalized at John Dempsey Hospital in Farmington.
Mm-hmm.
2 weeks go by and the local probate judge upholds the commitment,
Yeah, commits them.
commits him. That commitment is valid for 2 years. That's a long time. Am I wrong?
Yeah, you are wrong.
1 year?
Yeah.
I don't know if I feel any better.
You get an annual review after 1 year,
1
which
year.
is statutorily mandated.
I know, but that's you're in the
but-
that commits you for a year.
But you're jumping ahead. They could file a petition for release from confinement, because the person
Yeah.
over at John Dempsey will probably be transferred over to CVH if it's long
How
term.
many people you know who petitioned for an earlier?
I'm actually seeing about one every couple of weeks
That's-
now.
well,
Because I think the word is out among the patient population, they can do
But
it.
it's one, I mean, really,
No,
but
no, no, it is
statutorily,
relatively rare.
it's one year, once that you're there for 15 days. If the judge finds for the hospital, it's 1 year. I
Yeah.
think it's a big deal.
It is a big deal. I would want to be confined for 1 day, never mind a year.
Yeah.
Now, as far as, due process goes, we've already kind of touched upon this. Connecticut has really a very, very robust due process and also civil liberty protection. Because as we'll see shortly, we've already talked about, that it's a clear and convincing evidence standard. We need two independent psychiatrists. Well, we need two independent doctors, one of which has to be psychiatrists. We automatically appoint an attorney. So there's a lot of due process built into the system. Excellent.
If I may, and I know I'm interjecting a lot, but this goes back to the Lessard versus Schmidt decision that we spoke of earlier. The Wisconsin federal case. In that case, once somebody got committed to a hospital, they couldn't marry, they couldn't drive, they couldn't engage in any contracts, they couldn't vote. And what Lessard decided was that, no, you have to provide them with quote unquote due process. You got to give them notice. You got to let them know, you got to give them an attorney, et cetera, before you can take away all these rights by simply committing them to a hospital. All right, I'll be quiet.
No, you don't have to be quiet. Please, stop using the word interject. It's okay. We're helping each other out. Respondent has a right to counsel. It's almost always a court appointment, but you can have your own attorney. So if I get a call from an attorney anytime before my Friday morning hearings that they're representing Johnny Sick, to go back to that example, then as long as they file an appearance, so I know it's going to be them, they're more than happy to do that. The respondent, which means patient, once again, once the petition's filed, they're called a respondent, has a right to a 3-judge panel. In my 37 years, it's been used maybe 2 or 3 times. So certainly don't, please don't tell anybody about that. And the respondent has a right to cross-examine all the doctors, whether it's their treating psychiatrist or the independent doctor who'll be testifying. I always require my independent, and Dr. Zahidi's on board for next Friday, June 28th. That I always require my independent psychiatrist to actually attend the hearing, because it's kind of tough if you're an attorney to be cross-examining a piece of paper, a report. So I want my independent psychiatrist there. The benefit of having these hearings every Friday is that we can let Dr. Zahidi know. In fact, we just gave him the list a couple hours ago, that he knows that he's on for June 28th. He knows who he has to see, and he knows that he has to be there Friday morning. We are booked out now as far as doctors and also attorneys, probably till the month of September and maybe even October. So there is some benefit to that, to do volume.
As an anecdote, when I was a young doc training at UConn, whenever, and again, you're up and coming, you think you're the psychiatrist, you know everything. I always found it a little bit off-putting when the attorney assigned to the patient would vigorously and aggressively question me. I didn't fully understand it, but now I do, because that's their right. I don't take that lightly. You find yourself in a court of law trying to argue that somebody should be held somewhere against their will. Let them have their day in court. Let that attorney go to bat for them. I welcome it now, but back then I didn't fully understand it.
And there are some doctors who are still brittle at being cross-examined. So,
But
that's just the nature of the
I mean,
beast.
that's the thing. And I think my training in forensics allowed me to see that this is the patient's right. I mean, I don't think it's very therapeutic to sit there and argue for the detention of your
No,
patient.
that's another, right?
Right.
That's another
It's not
conversation.
therapeutic, but
Yeah.
it's good to see the attorney assigned to the patient put up a fight.
Yeah.
To unsettle the psychiatrist. That's part of the deal. That's the way it was supposed to be. It is supposed to be.
So the hearing's held within not later than 10 business days. It's not calendar days, so we're talking in essence a couple of weeks, 2 weeks, because it's 10 business days. Now, what is the respondent served with? They're served with the actual petition that tells them that there's a civil commitment hearing coming up. It gives them the date, obviously. It tells them, well, it told them exactly, because I've got the notice here. This is served in hand by a marshal upon the respondent roughly a week to 10 days before the hearing. Now when I say you, I mean the respondent. The patient has a right to be present, right to an attorney. If they can't afford an attorney, then the court will appoint one, and they have the right to enter the hospital on a voluntary basis. So going into the hearing, the respondent knows that they have all of these rights. So very, very important. And they're actually served in their hands by a marshal. Then the marshal has to return the service back to the court. So I know that the patient's been served by a marshal.
That goes back to Lessard versus Schmidt. Lessard versus Schmidt argued that if you're detaining somebody, that's tantamount to a criminal arrest. They requested some of these due process elements, including giving notice to the patient, et cetera, that these are remnants of that case.
All right, now, this is where Dr. Zahidi comes in. If it's a civil commitment, the statute requires that I appoint 2 impartial evaluating physicians from a list that Demas has. So I could only choose off that list. And one of the 2 doctors has to be a psychiatrist. So as I stated a couple minutes ago, Dr. Zahidi's on for next Friday, June 28th. He'll be the psychiatrist and he'll be testifying. I'm not sure who the other doctor is. They submit a report, but it may not be a psychiatrist necessarily. So what is the criteria that the Demas uses in order to get on that list? They have to be licensed in the state of Connecticut. They have to practice for at least 1 year. They cannot be connected with the hospital. Now, occasionally there's someone retires, when I say someone, I mean a doctor retires from a CVH or from Whiting Forensic Hospital, and a week after they retire, they get in contact with me, send me an email, give me a phone call saying, hey, I want to be one of your independent psychiatrists. The answer is no, because I don't think enough time has really gone by, because they'll be giving opinions on treatment that's been rendered by someone that they just were practicing with a couple of weeks ago. So I would like a little more time to go by before I would, hire that person as an independent psychiatrist. I have to personally examine the respondent no more than 10 days before the hearing, because you don't want, because it's, as you know, as Dr. Zahidi knows, mental illness is a very fluid situation. So a lot can change if it's more than 10 days. Even within 10 days, I get some reports, from doctors that are, within the 10 days, and I see a totally different presentation when the patient's before me, because things change so darn quickly. And then there's a form, we have forms for everything. There's a form that the doctor testifies from and then has to submit to the court, and that becomes evidence, is accepted as evidence by the court.
If I may, as the psychiatrist who does these evaluations, the statute says that I must personally examine the patient. And in my years of doing this, a question has come up because one has to go to the hospital, one has to evaluate the patient. And although this may not be true at CVH, every other hospital that does this has gone to an electronic health record. And since I'm usually not on staff, I have to request staff to give me access because, in my opinion, for a psychiatrist to do a personal examination, that should include a record review. It shouldn't be just my clinical impression. This has come up as a thorny issue as to whether or not the independent psychiatrist should have access to the chart. Now, going back to Judge Bazelon and Lake versus Cameron, Judge Bazelon was very specific. The independent psychiatrist should evaluate not just the patient, but give all the details as to why this person should be held against their will in the hospital.
All right. I just want to jump to the last bullet that's on this slide. The others are more pro forma. So the statute says that the respondent, the patient, can choose voluntary status anytime up until the adjudication of the actual petition, which means when a judge makes his or her decision. But it's not automatic. So I've got a patient there sitting, right across from me, and they, parrot the words perhaps that their attorney put in their, mouth, that they want to choose a voluntary, or they want to remain as a voluntary as opposed to being civilly committed. I always canvass them, which means ask them a series of questions, just to try to satisfy myself that at least on a basic level that they understand what it means to remain within that facility as a voluntary patient. So it's not automatic. And if they really don't know what it means, then I'm going to go through with the civil commitment until the very end. Next slide. All right, conducting the hearing, we have talked about this a little bit. The standard is clear and convincing. I would agree with Dr. Zahidi that beyond the reasonable doubt is probably about in the 95% range. That's a criminal standard. Clear and convincing falls somewhere between the 75 and 80% range, I think, as far as evidence, if you want to put numbers on it. So what are the findings that I have to make by clear and convincing? One, and remember all those definitions, that the respondent has psychiatric disabilities. Remember that definition. Two, is dangerous to self, others, or gravely disabled. But even if I make those two findings, the statute still requires that I then have to find that there's no less restrictive placement available. So even if they have psychiatric disabilities, even if I find by clear and convincing that they're dangerous to self or others or gravely disabled, is there less restrictive some sort of a placement available? That's where the social workers come into play. I always have the social workers, that Dr. Zahidi knows, they come to my hearings because that's the most important part, as far as the part that they play, because they're in touch with the community providers and they let me know out there for the person that they're committing them. And then if they are committed, as we talked about, continue for the duration of their psychiatric disabilities or until they're discharged.
And if as a psychiatrist, that this less restrictive environment is something that I've struggled with because the law, Lake versus Cameron, we talked about this, Judge Bazelon's decision, the less restrictive setting compels the court to discharge a patient if there is a less restrictive setting and if it's safe. The patient can still be exhibiting some symptoms where me as a provider think, you know what, this is suboptimal, this is not ideal, But the law compels the judge to say, listen, if there is a less restrictive setting, you got to let the patient go, even if the patient is still symptomatic.
True. All right. So, what's this? Yeah, we talked about having it at least every other year, but
See, I wasn't wrong.
no, you weren't wrong. True, there is a process. However, from my experience, I signed an memorandum of understanding, commonly known as an MOU, with the legal rights people on the CVH and also Whiting Forensic, hospitals, that we will have a review every single year uh, because the alternative required by statute, that's the baseline, that's the safety net, is that the patient can sign a piece of paper waiving their annual, but it can't be waived on the second year. But we felt that there were too many waivers, that the patient really did not understand what it is that they were waiving. And so we required every single year. In fact, I think Dr. Zahidi has 3 annual reviews next Friday, the 28th. Exactly for that reason. Now, I want to go back just very, very briefly. I often set up commitment reviews, what I call commitment reviews. There's no statutory authority for it, but it just seems like the right thing to do. So if I hear testimony during the civil commitment, which I grant, that perhaps 4 months, perhaps 6 months, maybe weeks even, that there may be a less restrictive placement available, then I just set the matter down for what I call the commitment review. I'll bring the patient back in if they're still there. I'll bring the social worker back in. I'll bring the treating psychiatrist back, back in, and then I get an update as to what is going on concerning the less restrictive placement. It keeps pressure upon the social workers to, keep on working towards getting the patient out, and also keeps pressure upon the community providers to, try to fashion some sort of less restrictive placement for this person. Nothing makes me happier than when I set a commitment review down and then I may not find out until I get to the actual hearing, which is fine, that in fact the patient's been discharged, often the day before, because I think they don't want to incur my wrath and find out that the patient is still there. And that's fine as long as they're out. All right, this is that 17A 510 that we talked about, to use that that scenario. Someone's committed by Judge Daly over in the Farmington Probate Court. It's not and I think that's John Dempsey, right? It's not a long-term facility typically, however you define long-term. So there's a superintendent's transfer. They end up at CVH, and the patient wants another judge to, take a look at that commitment. That's going to be me because now they're at CVH, and they filed this petition for release from confinement. Does not involve independent psychiatrists, so Dr. Zahidi would not get involved necessarily, but I just get testimony from the treating psychiatrist and from the social worker, once again, getting back to the standard concerning less restrictive placement being available. And then I decide if they shall remain under that original commitment signed by the other probate judge. If the answer is yes, then they'll be entitled to their annual review. Now, there's only a couple of these hearings a year, because you can see how it could be abused, and they may be requesting one of these every single month, which would be a waste of everyone's time. So they are limited to just 2 of these hearings a year. Now we're going to talk a little bit about
this actually applies to the root people, because that's where they write the PEC. It could happen to them.
All right, good. So as Dr. Zahidi mentioned, I think we touched upon this initially, that the PEC, the 15-day paper, call it whatever you want, can be signed by any doctor. It does not have to be a psychiatrist. What's the safeguard? The safeguard from the orthopedic surgeon filling out a PEC is that the patient, once they get to the ED, has to be examined by a physician, quoting the statute, specializing in the art of psychiatry, within 48 hours after they are admitted. So that's the safety net to make sure that we're really talking about a psychiatric disability and not some other issue. Now, as it's called, a 15-day paper means exactly that they could be confined against their will for up to 15 days.
The standard for that, I just want to mention that this is probable cause. It's definitely lower than the other standards we've mentioned.
It's that
It,
preponderance.
right, it's like, is it reasonable
Right.
to admit this individual? But I just want to emphasize how
Yeah.
much of a civil liberty curtailment such a decision can be.
Sure. Imagine being confined against your will for up to 15 days. I'm not trying to minimize
I
it.
mean, there are family members that like to do this too, but
That's, but it's a whole nother
right,
story.
right. Right.
Now, what's the safeguard? Where does the court come in on a 15-day physician's emergency certificate? It's called the probable cause hearing, which is that 51% that we talked about. So anytime during the 15 days, it's usually fairly early because no one wants to be there. The patient can, request a probable cause hearing. So that triggers very, very quickly because it's got to be held within 72 hours. So, I like to say 3 business days, but, but the statute says 72 hours from the time that the court receives it. I'll accept the facts because things happen very, very quickly, but it's 72 hours excluding, weekends and also excluding holidays. So it's really 3 business days. So they do have a right to counsel. Does not involve independent doctors. So basically, we just call the hospital, hey, I'm going to be there tomorrow. I just got this probable cause hearing request. We appoint an attorney. We have a good relationship because most of these come out of Middlesex Hospital, not out of the longer term facilities. And so I just told the social worker, set it up. We're going to be there tomorrow morning at 9:30. I let the attorney know that they've been appointed to go see the patient before the hearing. And then we go at that point. So there's no service by a marshal. There's no notification of any family members. There's really no nothing. We just have a hearing.
We're gonna have time for Q&A.
Yeah, what time is it?
It's 1:08.
1:08. Yeah, I think I only have about 5 minutes left. So,
Okay.
so probable cause, as we talked about, fairly low standard, 51% as far as I'm concerned. Forget about all this other stuff. Look at the last bullet under the first paragraph. I just look at would they benefit from further stay there? And that's, in essence, just a different way of putting it, advisability of continued treatment. So would they benefit from further stay? Now, even if I find probable cause, let's say we're on day 4 of the 15-day paper, and I do find probable cause, it does not mean that they have to stay there for the balance of the 15 days. It becomes a clinical decision. Sometimes they just need maybe a couple more days to get back on their meds or to increase the dosage or perhaps to get a shot of that 30-day long-acting intramuscular medication. So the fact that I find probable cause does not mean that they are confined there for the balance of the 15 days. So it's very, very important because they could be discharged within a couple of days, and that's fine. I do not have to be notified about that because my decision's a snapshot in time. I find probable cause today. They spend the weekend and they could be discharged Monday, and nothing makes me happier. Keep in mind that the facility has a burden of proof, so that 51%, has to be proven by the hospital. Now, voluntary, as I kind of touch upon a little bit, but it comes into play with the civil commitment that they can choose voluntary status anytime prior to adjudication. But what if someone simply wants to walk into a hospital? Well, they can do that as long as there's a bed available. They would sign some form that the hospital has. I don't think there's a uniform form. I've seen a bunch of these that various, I think, healthcare systems have different versions of the form, but they all say basically the same thing, that you understand what it is that you're doing, that you're coming into this hospital for treatment. But they do have to say, this is by statute, that they have to be notified that even if they want to, at that point, terminate the voluntary, that they may still be held for up to 3 business days after they terminate the voluntary. What's the point behind the 3 business days? Because within that period of time, either the patient gets discharged, or they bring when I say they, I mean the hospital brings a petition for their civil commitment, in which case they're held for up to 15 days after, till the court has the hearing, or they could rescind the termination and then stay as a voluntary. So they have to be told that, so they can't just walk out after they sign a voluntary within a couple of days if the hospital feels that it's not appropriate. Now, someone under conservatorship, it's a whole different ball game. So keep in mind, there's someone, a conservator, better terms, an adult guardian. So some court has already found them to be incapable of caring for themselves, but that doesn't mean that they can't sign a voluntary. So if a person that's under conservatorship signs a voluntary and they are admitted into a hospital, then a whole system has to take place. So the hospital notifies the court then appoints an independent psychiatrist, like Dr. Zahidi, to go see the person who is now hospitalized, but a very, very minor issue. The only thing that I need to know at that point from the independent psychiatrist is if they are able to give informed consent to their hospitalization. If the answer is yes, then it's over. They could stay there under the voluntary. If the answer is no, then the only way that the hospital can keep that person there is by initiating, bless you,
Thank you.
is, by initiating a petition for their civil commitment. That's the only way to do it. All right. Oh, I should also mention that a conservator does not have the right, not NOT, does not have the right to sign the conserved person in as a voluntary, so the actual conserved person, the actual patient has to sign themselves in, number one. And number two, by statute, a conservator does not, NOT, does not have the authority to initiate a civil commitment petition. So they cannot do that by statute.
All right, so the patient, we're almost there.
Yeah, we're almost there. So patient's bill of rights, this really comes into play for when we're discussing involuntary medication and also ECT. Once again, definitions are very, very important. Facility. So facility does not mean a skilled nursing facility, assisted living facility, rest home, boarding care, group home. It means exactly what it says. So all of those other, placements which I mentioned do not come under that term. Now the key here, the most important definition, which you're going to see over and over again, if you do any work in this area, is the patient capable of giving informed consent, whether it's informed consent to, psychiatric medication, whether it's informed consent to a course of ECT, also known as shock therapy. So if you're going to remember any of the definitions today, remember, informed consent. It means exactly that, because it really comes into play across the board. So you can read it on your own. I don't know whether Dr. Z, that you have an opinion concerning informed consent and how that definition really comes into play with what you see.
I think as clinicians, I think we all have an idea as to whether or not somebody is capable of, we call it capacity. Does the patient have capacity to agree to treatment? The question is whether they were made aware of what is happening. Do they have an awareness of their own predicament, and why are they choosing what they're choosing, and how they give value to the different decisions that they have made.
Right, because if I hear an involuntary med petition or a shock therapy petition, I first have to find that the patient is incapable of giving informed consent, either to psychiatric medication or to ECT. So, that definition, if it's a close call, then I always read it to the doctor who is testifying, and then I ask him or her, well, based upon that definition, does your patient have the ability to give, informed consent? And then I get an answer typically. If it's a close call, because I do have to make the finding, by clear and convincing evidence, the answer is no, then I'm going to deny that petition if it's a close call, because at that point, it doesn't meet the, clear and convincing evidentiary standard. I just want to touch very, very briefly upon shock therapy. That comes directly from the court. So it's a court authorizing it. It's after a hearing. Court has to find that the patient is, once again, incapable of giving informed consent to this procedure, and that there's no other less intrusive beneficial treatment. Very, very important. And if I do grant it, it's only good for 45 days. So it has to be renewed, assuming that they want to continue the ECT. The good thing about the 45 days is that I see what kind of progress the patient's made. during that initial course of treatment. You know, they might have received 10 or 12 treatments during that 45-day period, you know, maybe more. And I could see whether it's really had an effect or not.
I always get a kick out of this for the clinicians out there. If you can see, it says shock. This is from our general statutes.
Right.
Shock therapy, but there are other alternative electric current, insulin. I think this is insulin shock therapy.
It's an old definition.
I didn't know that we ever use carbon dioxide. I don't even know what indoclin is or similar agent.
Well, if you don't know, who the hell's gonna know?
Well, I mean, when was the last time you authorized that?
What, shock therapy?
No,
All the
shock
time.
therapy.
The other
Yeah.
ones,
No, ECT, I get it, but
Yeah.
insulin shock, I mean, that's
Actually, I had a good point by one of the doctors saying that they should change the statute because the word shock therapy, I mean, shock, it just kind of scares the hell out of you.
it's a term of art.
I'm not sure how softer ECT, electroconvulsive therapy, would be to the patients, but I think that's a valid point that at some point we may want to consider that, substituting ECT, electroconvulsive therapy, for the term shock therapy, but, it is what it is. That's what the statute says. That's all I have. So it's question and
Oh,
answer time.
beautiful. All right, so we are done, ladies and gentlemen. All right, so.
Actually, before we do that, let me simply say, you are all invited to attend any of my Friday morning hearings. We deal with ECT, we deal with involuntary meds, we deal with controversies, we deal with shock therapy. Just send me an email, which I should have provided on the slide, so I do apologize, but it's joseph.marino, M-A-R-I-N-O, at ctprobate.gov. So it's joseph.marino@ctprobate.gov. And if you tell me that you're coming, I just need your name and I'll tell you where to go, because it's CDH campus, which is where I start my hearings every Friday morning at 9, tends to be a bit of a maze. So you're more than happy to attend. Getting back to what I said, that I feel a large part of what we do is, really educational. So questions?
All right, ladies and gentlemen, there is one question. May I please have a copy of this statutory handouts or attachments? Okay, Daniel
do.
Bowen. Daniel, can I either email me or email the judge? I just put it in the chat.
Yep. More than happy to send that.
And then there's another, okay, do mental health professionals have a duty to warn? That's a little bit off topic, but I think that pertains to Tarasoff, and yes, that does apply in the state of Connecticut. It's not just warn, I think there's a sense of protection, especially if the victim is identifiable. Identifiable. The one thing I would say is if you come across a case like that, case consultation, case consultation, case consultation. Get everybody involved and make a decision by committee. I hope that helps.
It does help. Helps me.
I want questions. I don't know if my ego can handle people not being interested in asking questions. So please, if anybody has questions, good,
Well, they
bad.
can simply say it, right? Just unmute themselves and just
Right,
tell us what the
right.
question is. You
If
don't
not,
have to
we
write
could
it down.
let them go. I still want to know if I recognize anybody.
Are there any questions at all? Just
hold on.
unmute yourself. That's fine.
There's a Heather. Heather, thank you very much, Dr. Zahidi and Judge Marino. Oh, you're welcome, Heather.
You're welcome. You're welcome. Our
I'll
pleasure.
I'll just take the credit for the whole thing.
I knew you would.
So no questions. I guess maybe we weren't that informative.
Yeah, no, I think we were informative.
Okay,
I think we answered all their questions.
Oh, here we go. From Gabriel. Gabriel asked, okay. Does the hospital give the patients info on their rights when admitted? How do they know to petition the court? Excellent question.
It is an excellent question.
Excellent question.
Well
done.
If they're going to be civilly committed, once again, they're served by a marshal. If they come in voluntarily, the only thing that they need to know is that they have the right to that 3-day termination by signing a piece of paper. Do they find out that they have an annual review after they're committed? No, I don't think so. That really comes from the court at that point. And I think, yeah.
But not always. We didn't always. When it comes to the informed consent, the question is, was the patient educated on what's happening? I know that the Hartford healthcare system is doing a much better job at that and taking a moment to explain to the patient exactly what is happening, but it wasn't always the case.
Right.
It was not always the case. That's a good question.
Well, I asked the patient when we start the hearing every single time. I know Dr. Zahidi knows this. Do you know why we're here? It could be involuntary meds, it could be civil commitment, it could be shock therapy, it could be for appointment of a contravator. I just, would like to know. Often they do know at least the basics of why why they are there. But then I go into some sort of an more kind of detailed explanation of why we're there. I think it's important.
Also, but before they get to you, even in the ER, unless the patient is agitated, subject to IMs and what have you, time should be spent explaining what is happening, what the concerns are.
Yeah, keep in mind, if it's a civil commitment, they've already been seen before they come to me at time of hearing by the court-appointed attorney. They've already been seen by the two independent doctors. One's a psychiatrist like Dr. Zahidi. So, there's already three, quote unquote, strangers, if you will, that they're not familiar with, that they've seen heading into the process before they see me. So that should give them a sense of what they're, heading into and why they're there. Any other questions?
Yes. Could we go over again? I know you touched upon it earlier about if we feel that as a counselor here at Root, we call we call for the ambulance because the person is in danger. Does that person, and we think that that person needs to be in the hospital for a while. How do we get that person committed? What do we need to say? What do we need to send over information to the ED that makes us, how do we get this person to stay in the hospital longer? Because this person has been in and out of the hospital for so many times for suicide ideations.
Well, the only way to get him into the hospital is through the 15-day paper, which is what you would sign. And that would, I think, get him transported from your facility over to your local ED. Now, what happens there is, as I stated, they have to be seen by a psychiatrist within 48 hours. And if he or she confirms your findings on the 15-day paper, then they stay. They would have a right to a probable cause hearing. How do you keep them longer? Towards the end of the 15 days, in the hospital, wherever they end up, has to make a decision whether they should bring a petition for their civil commitment. They cannot do another PEC. You can't piggyback them. So at the end of the 15 days, either they're discharged or the patient signs a voluntary, or they wait until their civil commitment hearing if a petition's been filed. That's the only way to keep them there longer.
Ms. Shireen, I think what you're saying is, I can relate to what you're saying. I just did an evaluation at Capital Region where the patient is diagnosed with schizoaffective disorder, but also cocaine dependence. And whenever she's released from the hospital, instantly she forgoes treatment and goes to the dealer and somehow manages to get high. And in that process ends up getting raped or something else, which is, I don't want to say directly, but at least indirectly dangerous to her. The question is this grave disability? And every time I'm just trying to capture it, but I think at the time, if you have the concern that this person is unable, because of mental illness, to provide for their food, clothing, and shelter, which is the basic principles, then yes, you should send the patient to the ER. Then they have to do, the ER has to do its own evaluation.
It takes on a life of its own.
Right. They have to do, and they may not retain the patient. You provide the kind of input that is important for someone like me to come and testify, explaining that, listen, this person has had a revolving pattern of hospitalization. It seems like they are being deliberately disruptive to their own care, to their own stability. But the flip side is the patient has a right to act a fool. You see what I'm saying? They have a right. If they want to forego treatment and go do, I know exactly what you're describing, and there are some gray areas. And I just want you to appreciate that as much as you try to advocate for the patient's benefit, the law looks at it differently. No, people have a right to make their own mistakes. The question is, in this one case, on that one instance where you send them to the ER, are they choosing to do what they do, or are they really subject to the issues in their head that prevents them from making a decent decision? I hope that helps.
I see the same people over and over again over at Middlesex Hospital, not so much CVH and at Whiting, because they tend to be, well, one's forensic, the other one's more of a long-term facility. But folks come in on a 15-day paper, they may stay for the full 15, perhaps not. They're on they are back on their medications when they're in a hospital. So they're doing better, they get discharged, they're out in the community, they stop taking their medication. And then they're back in the hospital. And then I see the same people sometimes every, 2-3 months. Because the state of Connecticut, as you probably know, does not have any sort of, involuntary outpatient medication authority. So the patient has to be allowed, and I use that term loosely, to really hit rock bottom before they come back into the hospital. They stop taking their meds, whether because they're feeling better or because of the side effects. Once they're outside, they can't be forced. Once they're outside of the facility, outside of the hospital, and that starts to cycle over and over again. So we are one of a small number of states throughout the country that do not have some sort of version of an outpatient involuntary medication authority to try to prevent that cycling. But that's what we see here. But there's a strong bent in this state concerning civil liberties and protection of people's rights, as Dr. Zahidi said, to make a fool of themselves and to be a pain out in the community. I know it's frustrating. Trust me, it frustrates me too when I see the same people over and over again.
But they have rights. I mean, if anything that I hope to pass on is we are on the side of civil liberties. You have a right to do what you want to do. I can advocate for you. It's just we're talking about that narrow window where things can happen against somebody's will.
Any other questions? I think it's a wrap. What do you think?
I think we're good. Well, thank you, everybody.
All right, thank you.
Thank you, Root Center. I hope this was informative. And talk to you guys later.
All right, take care.
Bye-bye now. Okay.